All right, everybody, welcome back to the Medical Biochemical Genetics Clinical Core Seminar Series. This is week 5. It's August 18th, 2023. And this week we have Dr. Sean McCandless talking about amino acid disorders. Specifically, this week it's PKU, the tyrosinemias, and homocystinuria. So as always, CME information is going to be put in the chat at multiple times during the presentation. That'll include the code to get the CME for this session live, as well as the phone number you can text the code to, or the website you can link to put the code in. And if you could save questions for the end, I think probably that's the best format. That would be good. And just as a reminder, next week we have Dr. El Garbawi talking about carbohydrate metabolism. So with that, Sean, I will give you the floor and let you go.
Thanks, Pete. Great to be here. Hello, everyone. I'm on a laptop today, so I can't see anyone and I can't monitor the chat. So if you have something urgent to say, just unmute and interrupt.
Yeah, I'll call it out for you.
Okay, perfect. Couple of acknowledgements. Again, for those of you who've been to NAMA, you know that it's a great program, and I just want to thank many people who've contributed to the NAMA slide deck, and some of those slides I stole for this talk. Our learning objectives today, for those of you who, if you're younger than me, this reference may not hit home. So I put in a link that you can watch the Monty Python clip and get the reference. But really today I want to just follow up on what Nick you started a few weeks ago, talk a little bit more about the metabolic fate of amino acids. Talk about sort of the most common and most important of the amino acidopathies that you'll see in clinical practice, and then think about sort of various therapeutic approaches, both those that we're currently using and those in the pipeline. So when we think about amino acid metabolism, it's really, you know that amino acids in your body are, well, let's start with the structure of amino acids. There's the alpha carbon here with the carboxyl in the amino group. And Pete, can you see my pointer?
Yeah, I can.
Great. So you've got the carboxyl group of the amino group. This is what makes it an amino acid. The alpha carbon is the carbon to which those two molecules are attached. And then also attached to the alpha carbon is an R group, a side chain. And there are a variety of different side chains. Carboxyl, you can have carboxylic acids attached, you can have amine groups attached, hydroxyl groups. I assume that everyone knows what those structures look like, so I didn't put images of them in. But then some other stranger structures that you may be less familiar with: imidazoles. It's this 5-carbon ring with 2 nitrogens. Histidine is the only structural amino acid that's in that group. Guanidinium is a carbon molecule with 3 nitrogens attached to it. That's an unusual molecule. There's a number of those molecules. Arginine is the amino acid that has that structure. Guanididoacetic acid is an important one that we think about also, although it's not an amino acid. And then the thiols, cysteine and homocysteine. And the thiols are sulfur-containing amino acids. And then there's this common disulfide called cysteine, and cysteine with an I, T-I-N, and the amino acid is cysteine, T-E-I-N, and homocysteine. And so I'll try to make sure that the E is legible when I'm pronouncing the names of these. But these amino acids, the side structures are very important when you think about the metabolic fate of the amino acids. So amino acids, as you know, are the building blocks for proteins. Your body can also use them for energy, and they're also the starting place for neurotransmitter synthesis, for synthesis of hormones. And as part of the energy metabolism role that they are also very important as the building block for gluconeogenesis. So what happens to what does protein turnover look like in an adult? So if you take a typical 70 kilo adult, typical maybe not the correct term. If you take a stereotypical 70 kilogram adult that we all learned about in medical school and none of us have ever seen in real life, of those 70 kilos, about 11 kilos are protein. We're 60% water, 11% or 11 kilos of protein. And of that 11 kilos of protein, about 300 grams per day in a 70 kilo adult is broken down through proteolysis, just the turnover of proteins that have reached the end of their lifespan. Protein synthesis should in an ideal grams per day of protein synthesis that occurs. As proteolysis occurs, you create free amino acids, and those are the breakdown product of protein breakdown. And some of those amino acids, about 70 grams a day, undergo oxidation or irreversible degradation. And as a result of that, we have to have intake of amino acids from food or from de novo synthesis. And then some of those free amino acids go into specific functions each day. This is just sort of more for reference than anything else. It's the showing the pathway for irreversible degradation of amino acids, and particularly the carbon backbone of amino acids. And it shows the central role of what you clearly will recognize as the Krebs cycle, or the tricitrate cycle in the mitochondria, both for extracting energy from the carbon backbone of amino acids as they're being broken down, but also in the conversion to precursors to be used for gluconeogenesis, primarily oxaloacetate, pyruvate, but also for the recycling. So formation of alpha-ketoglutarate is very important in the pathway of synthesis of several of the non-essential amino acids. Some of the amino acids primarily make ketones, others primarily make glucose, and so there are some that make both, and so there are some you'll see well, there are a couple of examples. Leucine in particular. Leucine is, I think, the only one that primarily makes ketone bodies. Everything else, I think, can also be used as a substrate for gluconeogenesis. So phenylalanine and tyrosine come in through fumarate, and you can explore this on your own if you're interested in that. So when we're taking care of patients with amino acid disorders or organic acidemias, we always think about sort of what's going on in their body at any given time, turnover of protein and amino acids. And remember that the largest stores of protein in the body, the only way you have of storing amino acid is in protein. There's no other mechanism for storing amino acids in the body. And we'll come back to that in a minute. The largest stores of protein in the body are in muscle. And if you were to take a piece of skeletal muscle and measure the amino acid content of it, you would find that leucine is the highest concentration amino acid in muscle, followed by the other branch chains, valine and isoleucine, and then phenylalanine. So we often will say, oh, protein, there's 20 amino acids in protein, so they're each 5%. But the reality is that in our body, the bulk of the skeletal muscle proteins are leucine. Leucine is much higher concentration than others, and you can see that methionine is much lower. We talked earlier about we mentioned the concept of essential and non-essential amino acids, and you all know that essential amino acids are those that cannot be synthesized by humans. We don't have a way to make them, so they have to come from our diet, from protein in our diet. Non-essential amino acids can be synthesized by humans, And these are actually the carbon skeleton can come from glucose or other amino acids, and the nitrogen in the synthesis of amino acids usually comes from other amino acids, particularly glutamate. So, and then there are some that are non-essential unless you have an inborn error of metabolism that interrupts their synthesis, and so then they become essential. And one of the classics that Nick talked about is arginine, which if you have an intact urea cycle, you can synthesize arginine, but if your urea cycle is not intact, then arginine becomes an essential amino acid. Another way of looking at them with the gluconeogenic and the ketogenic noted as before. So when we think about protein catabolism, and this is particularly important when we think about metabolic decompensation, because it's all of you already know that for an inborn error of metabolism, that an individual with an inborn error of metabolism always has that defect. It doesn't come and go. It's always there. And the fact that people can live with those conditions and are not always sick is because they have other mechanisms they're able to compensate for the defect to maintain homeostasis. The cost of that, though, is that there may be production of other molecules, but also that they have very little reserve for absorbing increased flux through the pathway if there's a period of catabolism or metabolic stress. And I tend to use the term metabolic stress interchangeably with catabolism, because catabolism for a person living with an inborn error of metabolism is the primary form of metabolic stress. Other times some people refer to metabolic stress if there's oxidative stress, which is not incorrect. I'm not aware that there's a single definition. But when I refer to metabolic stress, I'm really referring later throughout this talk to situations where there is catabolism, and in the case of amino acids, particularly protein catabolism. So the protein content of muscle is about 20 grams per 100 grams of muscle. And if you sort of think about that, 100 grams of muscle is probably going to be close to 60 grams of water. And so half of the solid content of muscle is protein. The nitrogen protein is 16%. So the nitrogen containing protein content. So if one uses those numbers, you can see that 30 grams of muscle is equivalent of 6.25 grams of protein or 1 gram of nitrogen. Likewise, if one were to ingest 30 grams of beef, you would probably be getting about a gram of nitrogen that would need to be metabolized. This next one is obvious, but really important, and that is that amino acid composition of proteins genetically determined. You can't it doesn't depend on the diet. So if you're a weightlifter and you're taking in a single amino acid, it's not really doing that much special for you. You can't control what proteins are formed based on the dietary intake of amino acids. In catabolic situations, though, amino acids are released from muscles and are broken down and released from muscle through proteolysis. And that creates free amino acids that can then be used in protein synthesis or oxidized for energy. And the nitrogen that comes from those is converted to urea in an intact, if all the metabolic pathways are intact. So if you think about it, in a control person who has 100 grams of muscle, which is essentially 20 grams of protein, as they turn over proteins in that muscle, they're going to make they're going to make urea, which Nick already talked about, and they're going to release the 20 individual amino acids. This is coming from muscle. 8.5% of those are going to be leucine, and about 4% are going to be phenylalanine. And on the right, you can see what happens in a person with PKU. On the left, in a control person, those free amino acids are either used for synthesis of new proteins, or they undergo oxidation to eventually form energy plus CO2 plus water. And in a person with PKU, for example, that 20 grams of protein is about 800 grams of phenylalanine, and that phenylalanine has to be oxidized. So if there's a limitation of the pathway for phenylalanine breakdown, then you'll end up with accumulation of phenylalanine in tissues and in the bloodstream. And that is, in fact, the problem with PKU. I put this is a really old slide, back in the days where you had somebody sitting in an art department with a pen and ink making your graphs for your papers that you published. But the point is that we've known for many, many years that that protein turnover is directly related to body surface area. So there's a direct and linear relationship between body surface area and protein turnover and need for nitrogen excretion. I wanted to very briefly touch on a couple of other concepts that are important for protein turnover. One is feeding, which is often referred to as exogenous protein. And you eat protein, you digest it in the gut and release free amino acids as well as di and tripeptides. And some of those, and there may be rarely even slightly longer peptides that enter the circulation, and that's, can enter breast milk and cause allergies and sometimes in highly sensitive people. But most of the metabolism of most of the breakdown of proteins occurs in the gut. Very little occurs in after absorption. You get both essential and non-essential amino acids from food. And it really is the replacement. It's the source of replacement for the essential amino acids. If you have overall defective intake, if you have ineffective or inadequate intake of dietary protein, you will end up with a condition called kwashiorkor, which you may remember from medical school or may be familiar with, but you end up with a variety of protein deficiencies in important proteins, including albumin, which tends to lead to edema and fluid ending up outside of cells rather than inside of cells. Marasmus is the term that's used for a combined deficit of protein and calories. And I think these terms are important for us to be aware of, because we often create both of those conditions by the treatments that we give to our patients with inborn errors of metabolism. So it's just really important for us to be really clear about what we do to our patients sometimes when we are not paying attention, or when we don't understand what their nutritional needs really are, or when they're taking in less than we think they are. We can produce both kwashiorkor and marasmus, hopefully not in the severe forms that lead to death, but still always remember that those are in our country primarily iatrogenic problems. So with that sort of background in the first 15 minutes on protein metabolism, I want to then shift gears and talk about the amino acidopathies, and we'll hopefully cover most of the important ones that you haven't already heard about, and just remind you that the majority can be identified by existing newborn screening programs using tandem mass spectrometry. PKU, of course, is the paradigm for newborn screening and for an inborn error of metabolism. It's a defect in phenylalanine metabolism, which you know is an essential amino acid required for the synthesis of proteins, but is also a precursor for tyrosine. So in a person with PKU, tyrosine is now an essential amino acid that has to be delivered through the diet. Tyrosine is a precursor for catecholamines. Melanin, serotonin actually comes from tryptophan, I believe. Hyperphenylalanemias are conditions that are associated with the accumulation of phenylalanine in the systemic circulation. And we often refer to those as classic phenylketonuria, where the untreated Phe concentration in the blood is greater than 1,200 micromoles per liter. Mild PKU, where the untreated phenylalanine concentration in the blood is 600 to 1,200 micromoles per liter. And then hyperphenylalanemia, which is above normal, which is usually around, I think, 120 to 140 is the upper limit of the reference range in most labs. So anything between there and 600 we refer to as hyperphenylalaninemia. I think it's really important for all of us in the modern era to recognize that the units, milligrams per deciliter, are outdated and should not be used anymore. So if you happen to be in a place or are a person who tends to think in milligrams per deciliter, please retrain yourself to think in the agreed scientific term that the scientific community has agreed to use, which is, and the units are micromoles per liter. Okay, I'm stepping down from my soapbox now. Phenylalanine hydroxylase is the gene that's defective in PKU, in phenylketonuria. And that enzyme is a homotetramer of 4 copies of the phenylalanine hydroxylase protein. The functional enzyme has the actual enzymatic region is right in the middle, and there's these big side chains that are shaped like a butterfly that can change conformation to make it easier or harder for phenylalanine to get in to the active site. And so that allosteric activation of the phenylalanine hydroxylase enzyme is very important. There's also a required cofactor, tetrahydrobiopterin, that is reduced in the process of converting phenylalanine to tyrosine. I'm sorry, it's oxidized in the process of converting phenylalanine to tyrosine. And so that oxidized tetrahydrobiopterin can then be recycled, and your body also synthesizes tetrahydrobiopterin. There are multiple steps in that, starting with guanidine triphosphate. This biopterin, this pathway is also, there's evolutionary conservation and use of the tetrahydrobiopterin as a cofactor both for tyrosine hydroxylase, which is important for dopamine synthesis, and tryptophan hydroxylase, which is important in serotonin synthesis. And tyrosine hydroxylase is also important for melanin synthesis. PKU is primarily a disease of the liver, has autosomal recessive inheritance with an incidence of about 1 in 16,000 in the US. Various populations around the world have higher and lower frequencies of disease. It's important wherever you are in the world to know what the incidence of the disorder is in your region. It's a homotetramer, or in this case, a dimer of dimers. As I said before, it's allosterically activated, and that it's allosteric. That means that when there's high phenylalanine concentration surrounding the enzyme, it opens up, this structure opens up to allow to expose the active site, to allow oxidation or further metabolism of phenylalanine. So that enzymatically favorable conformation is stimulated by phenylalanine. Tetrahydrobiopterin also stabilizes the tetramer, but it does tend to support a lower conformation activity. So you need both that combination of tetrahydrobiopterin in the mix, as well as higher concentrations of Phe to have fully activated phenylalanine hydroxylase activity. So there are other causes of hyperphenylalaninemia. We talked briefly about the fact that defects in biopterin synthesis or recycling will also lead to failure of full activity of the phenylalanine hydroxylase enzyme. It's probably about 1% of classic hyperphenylalanemia, but also can present with very mild hyperphenylalanemia, but more severe defects in other in the formation of tyrosine-derived products or tryptophan-derived products. GTP cyclohydrolase, dihydropteridine reductase are some of the more common, 6-pyruvoyl tetrahydropterin synthase, and then the pterin alpha-carbinolamine dehydratase, which I only read just because I practiced in front of the mirror and I wanted to say them out loud. You can, a little bit of notes there. The first 3 typically also, you know, are earlier in the pathway. They all tend to present with hyper-Phe as well as deficiencies of neurotransmitters. And so treatment they're more difficult to treat. If you just put those kids, if you don't figure out that the kid has it, if you just assume they have phenylalanine hydroxylase deficiency, you can correct the hyperphenylalaninemia, but they'll still develop brain injury because of the neurotransmitter defects. And that's why it's absolutely critical in the workup of every patient with PKU to know with certainty the underlying cause of the PKU. Is it phenylalanine hydroxylase deficiency? Do you have two pathogenic mutations or likely pathogenic mutations? Or do you have some other measure that allows you to say that with confidence? It used to be that we measured a panel of the metabolites. That testing is of biopterin synthesis. Those tests are getting harder and harder to come by. And I think most of us now are primarily using panels of DNA sequencing to convince ourselves that the person does have PAH deficiency and does not have one of these other conditions, or alternatively to identify the other conditions so that we can treat it adequately. And that usually requires treatment with either tetrahydrobiopterin or sapropterin, and usually we use DOPA to replace dopamine if possible. The pterin alpha carbanolamine dehydratase tends to be a little bit milder, but still worth finding and starting treatment. And then recently, there's a couple of non-PAH, non-BH4 deficient causes of hyperphenylalanine. In particular, this JC12 is a molecular chaperone for a variety of hydroxylases. So those JC12 patients look similar to a tetrahydrobiopterin deficiency patient. Untreated PKU, we don't see very often anymore. It's a really severe condition. The kids, as you know, had normal development for the first 6 to 9 months of life, typically good feeders. The parents may refer to a mousy odor in the urine or just a strange odor in the urine. At around 9 to 12 months of age, there would be a slowing in developmental progress and head growth would slow. And by a year of age, usually the kids had clearly developmentally delayed. They were hypopigmented. They typically had skin defects, eczema, the odor. Many kids developed seizures. That continued to progress, and without therapy, severe intellectual disability and behavior problems. The behavior problems are very severe. It turns out for older people that are living in institutions or who, for whatever reason, have untreated PKU, you can't fix the intellectual disability, but treatment to control their phenylalanine concentration can really have a significant impact on the behavior problems and can make life better for both the individual and their family. The other thing that we don't see very often, but you used to in the past, was that you could have that could, if we had MRIs 20 years ago, we probably would have seen more of these white matter hyperintensities, which are a pseudoleukodystrophy. And I bring that up because if you have a patient that appears to have the leukodystrophy and for whatever reason they haven't had newborn screening, you should always kind of keep in the back of your mind the possibility of untreated PKU. And disturbingly, there are still cases being diagnosed even today occasionally, and even in the US occasionally. The pathophysiology of PKU is not that well understood. It's clear that the pathology is associated with the elevated total body content of phenylalanine. There's clearly measurable excessive Phe in the brain, phenylalanine Phe. There has been a hypothesis that phenylalanine can compete with other large neutral amino acids for transport into the CNS. And if you have an excess of phenylalanine in the plasma, that can interfere with and lead to deficiencies of other neutral amino acids in the CNS, including tyrosine and tryptophan, which are absolutely critical for neurotransmitter synthesis. And that leads to reduced synthesis of key neurotransmitters, especially during development. And then there is some data from mouse studies that suggest that phenylalanine itself inhibits tyrosine hydroxylase and tryptophan hydroxylase activity. There is no known pathologic effect on the liver, and there's no acute metabolic decompensation associated with phenylalanine. You don't get acidotic, you don't get acutely ill when phenylalanine concentrations are high. So the goal of treatment for phenylalanine or for defects of phenylalanine metabolism, like most of the things that we treat, is our goal is normal neurocognitive development with normal growth, normal social interactions, normal micronutrient concentrations, and normal bone calcium content. And it's really important when you're treating your patients and you're seeing them in clinic to keep all 5 of those targets in mind, because it's the fact that you may be meeting 1 or 2 or 3 of them doesn't mean that you're meeting all of them, and that can lead to problems in the future. So in terms of our treatment, we try to aim for a plasma phenylalanine concentration that is somewhere between the top of the upper end of the reference range, 120, to up to around 360 micromoles per liter with normal plasma tyrosine. And the 360 micromoles per liter is not, there's nothing magical about that number. It just appears that individuals that don't go above that tend to be normal in terms of development, growth, and all the things we talked about above. So that's where that number comes from. That's the target for treatment. There's actually some it's commonly held in our community that actually blood concentration of phenylalanine below 600 are associated with normal neurocognitive development. So somewhere between 360 and 600 is the safe zone. The goal is at the lower end of that, because phenylalanine concentrations go up and down. They go up when you're sick, they change during the day. And so if you try to keep your patients toward the lower end of the safe range, you can feel more confident that they won't be intermittently above the high end of the safe range. Therapy for phenylalanine for PKU in the past has been primarily targeted towards dietary phenylalanine reduction. And then 15, 18 years ago, competition approach by giving large neutral amino acid supplements that would compete for both absorption of phenylalanine and also lead to higher concentrations of the large neutral amino acids in the blood, which would then also lead to competition for improved competitive capacity for moving the large neutral amino acids into the CNS. Chaperone therapy with biopterin. We talked about how the biopterin stabilizes the dimer of dimers of phenylalanine hydroxylase. And so sapropterin is an artificial pterin that's available, also called Kuvan. And then enzyme substitution therapy has been approved by the FDA. Pegvaliase is the generic name of that compound. Palynziq is the trade name. I feel strongly that as medical professionals, we should, as much as possible, try to use generic names for compounds rather than trade names, so that there's no appearance to our patients or to our colleagues that we're giving preference to one company over another. There are also a number of experimental approaches that are ongoing, including gut biomanipulation that will hopefully pre-digest or pre-oxidize phenylalanine so that it's so that there's a reduction in absorption. And gene correction and gene replacement therapies are both in being worked on. Diet therapy remains a cornerstone for the majority of patients, at least initially in early infancy, before they're old enough to start the other therapeutics that are available. But also, most of the therapies are not 100% effective. So many people that do benefit from other therapies also require some dietary restriction. In classical PKU, phenylalanine intake is usually about 250 to 300 milligrams per day, and that actually doesn't change much from infancy, early childhood through to adulthood. And remember that 1 gram of dietary protein is about 50 or 60 milligrams of phenylalanine, or 45 to 55. So that is not much protein, dietary intact protein for a person with classical PKU. That's a hard diet. We supplement with phenylalanine-free medical food, which is basically giving amino acids, an amino acid mix that does not contain pyr or phenylalanine, or has very, very low concentrations of phenylalanine. So some of the special formulas, most of the special formulas are elemental formulas. They're made from a mixture of individual amino acids rather than from an intact protein. There are products called glycomacropeptides that is a byproduct of casein and cheese production that is it's peptides that have much of the same physical properties as protein, and but it is much lower in phenylalanine, so you can make cheese and you can make foods that have a more natural protein-like texture using these glycomacropeptides. They unfortunately tend to be a little bit expensive and are not, you can't just go to your local Kroger and buy them. We also need to really pay attention to vitamins and minerals, because if we're avoiding intact protein and a lot of typical foods, particularly milk and other things in infants, we have to be really cognizant of the fact that we have to pay attention to vitamins and minerals. The other thing that's really important is that with dietary therapy, um, remember you can't store amino acids in your body. So if you give somebody a whole bunch of their phenylalanine-free amino acid supplements all at one time, they'll make some protein from it, but the rest of it will just get oxidized and it'll be gone. And then the rest of the day, they're going to be deficient in the essential amino acids, including phenylalanine. Well, phenylalanine, they won't be deficient. They'll have plenty of that, but they'll be deficient in tyrosine and other things. And so it can inhibit. So if it's really important to distribute the medical food through the day so that there's always a source of amino acids being absorbed from the gut. And then diet for life probably should refer now, we should probably say treatment for life. You can't stop treating PKU. We learned this the hard way. You can have a kid grow up and have normal intelligence, but when they go off the diet, when they go off treatment, phenylalanine concentrations go up. There's one study that demonstrated that in adults with normal intelligence to start with, when their phenylalanine concentration goes up over 1,200 to 2,000 micromoles per liter, they lose about 15 IQ points, and that's reversible, at least in the short term, if you reinstitute the phenylalanine correction. So treatment for life is a key phrase for treatment of PKU. Breastfeeding is a really important issue. Many parents, when they are breastfeeding, when they find out that their baby had an abnormal newborn screen, and in the past that was automatically no breastfeeding, go on medical food. Now, many dietitians are willing to try breastfeeding because we have to give intact protein to provide some phenylalanine. And so we try to provide that. We try to give, in these babies, we try to aim for getting their as much phenylalanine as they can tolerate from breast milk. And you can do a couple of ways. You can mix breast milk and formula in a bottle and bottle feed, or you can alternate feedings, at one feeding at breast, one at bottle. Some people will do the bottle first with the metabolic formula prescription and then allow the child to attach to the breast. And So a couple of points there for breastfeeding. The initial breast milk that comes out tends to be very watery and protein rich, and the hind milk that comes toward the end of a breastfeeding session tends to have more. It'd be a richer food, and it has more fat in it. And so there's a couple of strategies that people will use. Sometimes they might ask the mom to pump for 5 or 7 minutes before putting the baby on the breast to get that fore milk out. Or the other thing is, if mom's gonna breastfeed, to have her only feed on one side so that the baby does get to the hind milk on that side, and then alternate sides. Moms will need to pump if they're doing that. Lots of different ways to try it. and you just kind of work with your family to find something that works for them. And if it doesn't work, you just say we gave it our best shot, and you go to all medical foods. This is really more for your reference, just sort of the recommended intakes for individuals with classical PKU for Phe, tyrosine, and protein. I do want to point out here, though, that for a person with PKU in the third trimester of pregnancy, so a mom who has PKU, she may well have as much as a 5 or 6 fold increase in her need for phenylalanine. So during pregnancy, you have to be measuring phenylalanine and tyrosine usually weekly to stay on top of it. And tyrosine, the babies just suck phenylalanine and tyrosine out of mom's circulation. So you often have to supplement tyrosine in pregnant women in the second and third trimesters. And then likewise during lactation, you just need to be really careful in measuring. And this is when mom has PKU. You need to be really careful in measuring concentrations. Monitoring is very important for dietary therapy. You need to monitor growth, make sure they're getting adequate calories, make sure that they're getting adequate protein, vitamins, and minerals, measuring amino acids to ensure that we're giving the appropriate mix of amino acids and there's no deficient amino acids. Measuring amino acids doesn't tell you if you're giving too much of any one amino acid because your body will metabolize it. But if you're deficient, if you're deficient, that becomes apparent. Obviously, you need to monitor blood Phe and tyrosine. Every clinic has a different schedule that they use. It's also important to monitor other parameters from time to time, including iron and vitamin D, and also careful developmental history, social history, and staying on top of that is really important. And the last statement on this slide, working with a dietitian who's knowledgeable about inborn errors of metabolism, absolutely critical. As metabolic specialists, we are not trained to understand the nuance of everything that's going on in this diet. So you really have to have a partner. Again, frequency of monitoring, every clinic does a little bit differently. The keys are the younger the patient, the more frequently you need to monitor. And if things are poorly controlled or you're making changes, you may need to monitor more frequently, and just be aware that phenylalanine does go up when you're sick. We talked about other things to measure, transthyretin and amino acids to monitor adequate protein intake, micronutrients, iron status. So I want to switch gears now and talk about some of the alternative therapies besides dietary therapy. Large neutral amino acids. The goal is to give 20 to 30% of the medical food, give of protein content each day as large neutral amino acids. It does not require any functional phenylalanine hydroxylase protein to work, but the data on efficacy are kind of mixed. And I would say that there are very few patients that I'm aware of that this is their only treatment. The concept is that you, at least on the brain, at the blood-brain barrier, the neutral amino acids, including phenylalanine, tryptophan, tyrosine, are transported by LAT1. This is a neutral amino acid transporter. CAT1 or Y plus protein is responsible for transport of some of the cationic lysine, arginine. And there's a couple of other transporters for other amino acids, but the large neutrals are what transport phenylalanine. So the idea is if you have a high concentration of other large neutral amino acids, leucine, isoleucine, valine, on this in the blood, they will compete better with phenylalanine to get transported into the CNS. So that's the hypothesis there. There's also a suggestion that can work at the level of the gut as well to increase or to decrease absorption of phenylalanine and to enhance absorption of other large neutral amino acids. This is some of the proposed mechanism for how large neutral amino acids might help treat the brain dysfunction. And here you can see that by the hypothesis is that when you have this over competition of phenylalanine, because you have when phenylalanine is overrepresented, it's over competitive. You end up with high phenylalanine in the CNS, low large neutral amino acids. You get reduced protein synthesis because you don't have enough amino acid precursors. You get low neurotransmitters. The high phenylalanine itself may be damaging to myelin. It may inhibit tyrosine or tryptophan and tyrosine hydroxylases. And then there's some other experimental evidence of other potential defects that occur as a result of high phenylalanine in the brain. Sapropterin is a analog of tetrahydrobiopterin. The goal of sapropterin therapy is to enhance Phe tolerance and normalize the diet by stabilizing and activating residual phenylalanine hydroxylase activity. So it's important, so you have to have some residual enzyme activity for this treatment to work. So if you have two null alleles, this treatment doesn't work. The typical dose is 20 milligrams per kilo per day. It's given as a single dose once a day. In other places I've worked and in some parts of Europe, they often will give a therapeutic trial. So a kid comes in with an abnormal newborn screen, their blood phenylalanine's 1800, give them a 24-hour trial of sapropterin. If they have a 30% reduction in phenylalanine with no dietary intervention, that tells you that they are sapropterin sensitive. It's also a diagnostic maneuver for the biopterin deficiencies. And so if this will work in your system, it's a really nice way of understanding whether they may be sensitive to sapropterin and quickly identifying those kids that are unlikely to have a pure phenylalanine hydroxylase defect. After the first 48 hours of life, it's recommended that the Kuvan trial or the sapropterin trial be a 30-day trial. Again, looking for a 30%, starting with a stable blood phenylalanine, looking for a 30% reduction after you add the drug. And it may take a while for the drug to work. Here's just a list of some mutations that are known to be sapropterin responsive that are available in the literature, and this is being constantly updated. This particular list I took from Gene Reviews. Pegvaliase is the therapy that everyone's excited about right now. That's an enzyme replacement therapy, but not with the human enzyme. It uses a plant enzyme called phenylalanine ammonia lyase. And there's a couple of important points about that. Because phenylalanine ammonia lyase just breaks the nitrogen group off of the phenylalanine to make an organic acid called transenamic acid, you don't make tyrosine, unlike phenylalanine hydroxylase, which forms tyrosine. So if you use this, you still need to supplement tyrosine to make sure that the person's getting adequate tyrosine. The good news is if it works, you can eat more intact protein in your diet and probably get all the tyrosine you need from there. Immunologic reactions are very common. In the clinical trials, 10% of people had anaphylactic reactions, and anaphylaxis can occur at any time, often as you're starting treatment, but there have been reports of people developing anaphylaxis years after they started pegvaliase therapy. Another big problem is that there's arthralgias, which are thought to be an immunologic response, occur in like 85% of people at some point when they're taking pegvaliase. And so those have to be managed. The good news is they generally are self-limited. Because it's a foreign protein, the body recognizes it. It's very common for people to develop neutralizing antibodies against the PAL. And the result of that can be that there's poor efficacy of the drug. And so there's not 100% efficacy, which hypothetically there should be. Interestingly, if your patients develop neutralizing antibodies over time, they tend to become less. And what you'll see is that over time, including in some cases over years, people may actually require very high doses to get a therapeutic effect. And then once their neutralizing antibodies start to taper off, they may be able to taper the dose of pegvaliase and still get better effect. So the effect can take a while to see to kick in, and it can continue to improve over time. The drug's currently approved for use in 16 years and up. It's not approved for use during pregnancy. There is, again, like most of the drugs that we encounter, there's some animal data suggesting that at very high doses you can have low weight gain and some malformations associated with use of pegvaliase. Having said that, in the animal studies, it appears that it's almost always associated, you almost always have maternal complications of the treatment with the extra high doses. And that when you give a dose that's well tolerated by the mother, the pups are less likely to have problems and may not have any problems. As said, approved for 16 years and up in humans, and there is a clinical trial, I believe, that's happening right now to try it in people 12 to 15 years of age. Typical dose is 20 milligrams per day as a subcutaneous injection. The package insert I'll show you in a minute has titration recommendations. Response is defined as at least a 20% reduction in the baseline plasma phenylalanine with no change in dietary phenylalanine intake. And typically the recommendation is that once you get up to the current maximum dose of 60 milligrams per day, if you've been on that dose for 16 weeks, and just to point out, 60 milligrams per day is 3 shots a day. 16 weeks with no response, then that's considered a drug failure and they recommend stopping. That said, it can take more than a year to achieve the full response. So you have to make those decisions with your patients. The reason I mentioned the 3 shots a day, if you're on 60 milligrams, is that there's a very high rate also of local reactions, including getting really firm, inflamed nodules where you give the injection sometimes, and even some granulomatous problems that can get infected and be really kind of a problem. So it's not the easiest drug in the world to use. Here's the current recommended titration, up to 60 milligrams a day. There's been at least one case report in a few patients that didn't respond to 60 milligrams a day who went up to 80 milligrams a day and did have some response. So this may continue to change. Now I want to shift gears and think about a condition at the time that newborn screening for PKU and treatment of PKU started in the late 50s, early 60s. A number of people predicted, including one of my former colleagues, Henry Kirkman at the University of North Carolina, who was a very well-known metabolic geneticist at the time, recognized that with the treatment strategies then of treating children and then letting them go off the diet once their brain was fully developed, that there would be a big problem with phenylalanine exposure in fetuses when those women that had PKU and went off diet then became pregnant as in adulthood. And that was exactly what happened. And unfortunately, it's still happening. Phenylalanine is teratogenic. It causes brain injury, microcephaly, it causes cardiac lesions, and children born to moms that have uncontrolled PKU typically have intellectual disability, and it can be quite profound. And the microcephaly and heart lesions are very common. Microcephaly is common even in moms that are partially treated or start treatment and get their blood under control, but have high phenylalanine during the formative embryogenic period. Ideally, you want to start therapy or get mom PKU phenylalanine controlled before she becomes pregnant. If mom becomes pregnant and is not treating her PKU, the goal is to get to the treatment range as quickly as possible, and that may mean, in some cases, even bringing mom in the hospital for aggressive dietary management for a few days to get the phenylalanine down. If you were on a phenylalanine-free diet, entirely phenylalanine-free diet, typically the phenylalanine concentration will drop by half every 36 to 48 hours. So if mom comes in at 2,000, you put her in the hospital and give her a completely phenylalanine-free diet, or do it at home, which is harder. Within 4 to 5 days, she's probably going to be down to a reasonable concentration of blood phenylalanine. Phenylalanine is highly concentrated as it crosses the placenta, though, so you have to be really careful with the mom's blood level. Sapropterin seems to be safe for use during pregnancy, and the risk, although it's not approved for use during pregnancy, for both patients that are successfully using sapropterin and pegvaliase, you really have to very carefully consider the potential harm of not treating the PKU, which we know causes severe problems. So if there's a hypothetical risk of harm related to the treatment, but you're keeping the mom's phenylalanine normal, you have to have a pretty compelling reason. And you have to be fairly confident that that mom has the capability to control the blood phenylalanine without the supplemental therapies, if to take her off the drug. And for many women, the risk of staying on pegvaliase or sapropterin is lower than the risk of having a poorly controlled PKU. So just briefly, a couple of universal lessons about PKU. Screening and treatment can be effective. When we started screening for PKU, we recognized that hyperphe was a thing. Milder cases can be uncovered. That's true with just about every condition for which newborn screening has been initiated. There may be unanticipated future consequences to treating inborn errors in metabolism that we need to be thoughtful about. Treatment or intervention creates a new natural history. If you think that adults with PKU are normal now, you haven't seen very many adults with PKU. There's still a wide variety of problems, a lot of anxiety issues, still a lot of challenges with day-to-day life for people with treated PKU. Pathogenesis is more complicated than you think. We usually, sometimes we go into newborn screening with thinking, oh, I do this, we figure out they have it, we give them this simple treatment, everything's good. It's never that simple. And along with the natural history of the disease changing, alternate therapies may well be developed over time, and that's very important too. So I want to very briefly talk about tyrosine catabolic pathway, which is shown here. I'm not going to go into too much detail, except that the most important defect for us to know about is the fumarate acetoacetate hydrolase deficiency, FAH deficiency, which is type 1 tyrosinemia, also called hepatorenal tyrosinemia, because it causes liver and renal damage. Also called hereditary tyrosinemia type 1 or HT1. Succinyl acetone accumulates, malonyl acetoacetate accumulates. Succinyl acetone interferes with a couple of things. It in the kidney is thought to be the cause of the tubular injury and causes a Fanconi syndrome. And it inhibits porphobilinogen synthase, which is required for making aminolevulinic acid into porphobilinogen. And so you get these porphyric crises from high concentration of succinyl acetone. So tyrosinemia type 1 is often associated in later life with acute neurologic and pain crises similar to porphyrias. So the fumarate acetoacetate hydrolase deficiency is a recessive disorder. There's a founder effect in northern Finland and in Quebec, where they have much higher incidence of the disease. Depending on the severity of the enzyme deficiency, you can have present in early infancy with liver disease, and those kids often died before they were diagnosed, before newborn screening. A later infancy presentation with tubulopathy and kidney disease and developmental disability. And then even the porphyria-like neurologic and pain attacks can present at any age. And so sometimes even older kids will present with this. even though this is thought to be a toxic, the damage is caused by a toxic compound, it's not an intoxication syndrome. So you don't get intoxication symptoms, which is altered mental status and acute changes when you have a metabolic flare up. So it's long-term quiet damage in this case. It's not entirely clear whether it's just succinyl acetone or whether fumarate acetoacetate and malonyl acetoacetate also cause problems. Succinyl acetone's not, it's not, usually you don't have very much of it at all. It's an alternative metabolite. If you can't get rid of fumarate acetoacetate or even malonyl acetoacetate, you'll make succinyl acetone. It does cause these toxins, whichever one it is or something else, does cause cellular damage, and you can eventually get tumors in the liver from that. And then the kidney damage, so you get a renal Fanconi syndrome, hypophosphatemic rickets, and then intellectual disability is very common in untreated patients. We already talked about the succinyl acetone inhibition of inhibiting aminolevulinic acid dehydrogenase, delta ALA, dehydratase activity causing that porphyria-like abdominal crisis and peripheral neuropathy. And then the other enzyme to be aware of is 4-hydroxyphenylpyruvate dioxygenase, which is the enzyme that's defective in tyrosinemia type 2 that we'll talk about in a minute, but it's also the target of treatment for type 1. And the treatment is 2-nitro-4-trifluoromethylbenzoyl 1,3-cyclohexanedione, which for obvious reasons we typically refer to as NTBC. The trade names are Orfadin and Tycir, I think, Ty something. There's a generic form now that's available. No reason that I'm aware of to think that one works better than the other. They're essentially the same drug, NTBC. It inhibits 4-hydroxyphenylpyruvate acid dioxygenase and causes people that have tyrosinemia type 1 to now have tyrosinemia type 2. And the good news is that tyrosinemia type 2 is a milder disease, which you can treat with diet. And you don't accumulate the toxic compounds from tyrosinemia type 1, and so you markedly reduce the risk of hepatocellular carcinoma, intellectual disability, and renal Fanconi disease. You do have to restrict dietary phenylalanine and tyrosine, though, because the patient does have now, because of the drug treatment, tyrosinemia type 2. And liver transplant is also a treatment will correct tyrosinemia type 1 if you have a reason to do that, which is typically hepatocellular carcinoma. So nitisinone is the generic name for NTBC. There's a couple of ways to monitor treatment. It has been reported that if you have plasma concentrations greater than 35 micromoles per liter of nitisinone, that you get 99.9% inhibition of the enzyme, and that's all you need to work. So some places just suggest monitoring the drug concentration. As long as the blood concentration is adequate, you don't have to measure anything else. I personally have never been comfortable with that, and I always monitor either plasma or urine succinyl acetone because I want to see complete suppression. The other thing is that in my experience, for what it's worth, there's a little bit of wiggle room for each person, and the dose of nitisinone is usually 1 milligram per kilo per day, and divided BID you can get away with once a day, especially in older kids. But I like to titrate the dose to keep the succinyl acetone, the lowest dose possible, to keep the succinyl acetone completely suppressed. And the reason for that is that if you overdo it with the drug, you really run into trouble keeping it's hard to keep the tyrosine low. Within the treatment goal range. And so sometimes you just want to walk this balancing beam of keeping the nitisinone dose just right to make the tyrosine manageable and to keep succinyl acetone fully suppressed. There is no data to support that approach. And so you have to decide for yourself with your patients what's going to work best for you. And so any of these approaches probably are adequate right now. There is dry blood spot testing available for succinylacetone and some of the other things, but in our experience and in the experience of some others, the drug concentrations don't correlate well with the plasma concentrations. And so use these with care and maybe don't rely entirely on the dried blood spot monitoring. This is just to show the various places in the pathway where you have defects of tyrosine metabolism. So you've got the phenylalanine defects here, type 2, type 2 and type 3 tyrosinemia that we'll talk about in a minute, alkaptonuria here. And then I just added this malonyl acetoacetate isomerase. And the reason that we're bringing this to your attention now is that this is the step before FAH, which is tyrosinemia type 1. We used to think that newborn screening using succinylacetone was highly sensitive and highly specific for tyrosinemia type 1. But then when we started doing it, we realized that there were kids that had persistently elevated succinylacetone who didn't have genetic changes to suggest that they had tyrosinemia type 1. And it turns out that there are defects of this MAAI that are thought to be clinically benign, but can lead to persistent succinylacetone elevations and abnormal newborn screen. So now just to keep that in mind, if you get an abnormal succinylacetone that's persistent, you should probably do DNA sequencing to confirm whether it's FAH deficiency or MAAI deficiency, because MAAI deficiency probably does not require treatment. At least that's the current thinking. Urine organic acids may show an increase in maleic acid in the majority of these patients, but it may not be 100%. Other metabolites that you could see, tyrosine, tyrosine turned out to be a terrible newborn screening marker for tyrosinemia type 1 because it's so far back the pathway that you didn't get much tyrosine buildup. So most of the time, if tyrosine's elevated on newborn screening, it's one of the more proximal diseases in the pathway. Other metabolites you can see in the urine are the 4-hydroxyphenyl compounds, pyruvate, lactate, acetate. Tyrosinemia type 2, which is tyrosine aminotransferase, also called Rickner-Hanhart syndrome, quite rare, marked primarily by the development of corneal crystals, which is really, really painful in the first year, usually developed by a year or so of age. Some of those kids will also develop intellectual disability, and they get these really weird hyperkeratotic patches of skin on the palms and soles of their feet. They can have pits in them. They're often painful, and 60% of patients untreated will develop intellectual disability, typically by between 1 and 5 years of age. And then, so this is treated with low tyrosine diet, low tyrosine, low phenylalanine diet to keep tyrosine typically below 600. And it usually prevents all of the symptoms, and you have normal intellectual development with that. It's quite rare, 1 in a million. It's really, you don't see it, but it's essentially the same as treated tyrosinemia type 1. A patient with tyrosinemia type 1 on nitisinone, it's not the enzyme, but they have the same symptom. They can develop the same symptoms, we think. Although again, not enough data to know for sure. Tyrosinemia type 3, which is the enzyme inhibited by nitisinone, also rare. Ocular findings have not been reported, but they have been reported with nitisinone, so there's no reason to think that the naturally occurring defects wouldn't have some risk of that. They don't typically get the skin findings. Treatment is there's another condition, type 3, which is, or type 3, it's not type 3, it's the dominant form of that enzyme is called Hawkinsonuria. And so that one is not really a clinically significant disease, but you do, for whatever reason, if carriers of that HPA dioxygenase defect can create this weird amino acid called Hawkinson that's basically a cysteine on a tyrosine molecule with this sulfur bond between them, but not is typically a benign condition, to the best of my knowledge. It's such a rare condition, type 3, that we don't really know whether some people think that it may be mild because there've been some adults reported who are reportedly normal. At the same time, there've been people with seizures, but it's not clear that whether there were other things that might be causing the seizures. The bottom line is we don't know much about type 3. And so the safest course, if you do come across one through newborn screening or through clinical evaluation, is to treat them fairly aggressively. That may be overtreatment, may be unnecessary, but we don't know that right now. And until we do, it's probably safest just to do that. The treatment is similar to other forms of phenylalanine and tyrosine metabolism, just reduce the dietary problem. Try to keep plasma tyrosine under 600. That's an empiric observation, no real data to support that other than experience. Monitor development, regular eye checks, and skin checks. I wanted to briefly talk about transient tyrosinemia of the newborn. We still don't know for sure what that is, but it's thought to be due to immaturity or delayed expression of the type 3 tyrosinemia enzyme. And there may be some feedback on some of the earlier enzymes in the pathway too that inhibit them. Clinically, it's a self-limiting condition that you see primarily in premature infants, but occasionally in a term infant. It appears to be benign, even though the tyrosines can be over 1,000. It's fairly common, 1 in 250 premature infants, 1 in 250 to 300. There's older literature that suggests that ascorbic acid can lead to quicker resolution, but that has that's not been well documented. Ooh, I jumped ahead too soon. I was going to say that the key to this is that if you get a high tyrosine in a newborn screen, probably the easiest and best thing is just to wait 6 weeks and then get plasma amino acids so that the transient tyrosinemias go away. You don't really need to aggressively intervene for type 2 or type 3 tyrosinemia until the babies are at least 6 months of age, so you have time. And those conditions are very rare. This condition is very common. So the simplest thing is just to let them outgrow it before you get aggressive and do anything else for elevated tyrosine on newborn screening. So now this moment of evolutionary knowledge is brought to you by Pete Baker. The last topic for today is to talk a little bit about conditions that lead to accumulation of homocysteine. And I put this nice pathway in here to show this compound, S-adenosylmethionine, which is very important because of this methyl group right here. This is the primary one carbon donor in a variety of metabolic pathways and synthetic pathways in the body, S-adenosylmethionine. And it's a pretty complicated way that the system has evolved to work with this complex molecule, S-adenosylmethionine, that comes from methionine. And in the breakdown of it, you get rid of the methyl group and you now have S-adenosyl homocysteine, where the adenosine is broken off and you get homocysteine. Homocysteine can either be degraded to make propionic acid and alpha-ketobutyric acid, which is a ketone, or it can be recycled or remethylated through the remethylation pathway, and that's shown here. So there's two forms of homocysteine accumulating defects: transsulfuration, classical homocystinuria, and remethylation defects. And that includes the defects of vitamin B12 metabolism that affect the formation of methylcobalamin, because methylcobalamin is a required cofactor for this homocysteine methionine methyltransferase. And then there is a treatment. There's an enzyme in our body that will take a compound that we don't make naturally, but you can, if you eat lots of beets, you'll get it. betaine or betaine, and betaine can be the methyl donor to form dimethylglycine plus methionine from homocysteine. So this is a complex pathway, tetrahydrofolate in here, glycine and serine metabolism impact it. There's a lot going on in this pathway. Just wanted to give you this for reference, the methionine, homocysteine, and then the disulfides that form homocysteine. What we see, you can see that in urine, and that's where the name homocystinuria came from. It's just a disulfide compound of two homocysteines linked through a disulfide bond. A couple of things that are important. Homocysteine measurements are really important. It's best to measure total homocysteine rather than relying on measurement of homocysteine here. The reason for that is that this breaks down very rapidly in in samples and deteriorates. So if you want to measure homocysteine, you have to immediately treat the sample with a strong acid to stabilize the peptide. It's much easier to just allow it to degrade and measure total homocysteine. And so basically when you measure total homocysteine, you treat the sample to break down all of the disulfides into homocysteine. You have to deproton. So if you do have a reason to measure homocysteine, then you need to deprotonize with a strong acid. So with that in mind, measure total homocysteine. It's available in almost every automated chemistry lab in the country. Classical homocysteine is the defect in the transsulfuration pathway. It's the primary cause is cystathionine beta synthase deficiency. It's a recessive disorder, somewhat rare, but we do see it. It's probably more rare than you would expect for how famous it is. But there's also probably incomplete ascertainment. And newborn screening programs that claim to be screening for homocystinuria are screening for it by looking for high methionine, which is seen in CBS deficiency, but we probably miss half the cases. And so there's a lot of people that are very interested in developing homocysteine measurement as the newborn screening test, which should pick up 100% of cases of CBS deficiency and would have the benefit of picking up some remethylation defects as well. It's important to point out that that we do miss cases of homocystinuria by newborn screening, and so you have to be on the lookout for that in your clinical practice. Of CBS mutations, about half are pyridoxine responsive. They respond to vitamin B6. So when you diagnose a kid with homocystinuria, the first thing to do is put them on high-dose pyridoxine and see if the homocysteine comes down. Because some people can get by with just pyridoxine therapy, but many don't respond. Classical untreated homocystinuria has a morphinoid habitus that you could easily confuse this person for having Marfan syndrome. And the skeletal manifestations are most common in the non-B6 responsive forms. Ectopia lentis or dislocated lens is very common in untreated or poorly treated homocystinuria. And even in treated homocystinuria, you'll see it. Typically down towards the nose, which is the opposite of Marfan. It's not 100%, and it's something that people love to talk about for trivia, but if you ever see this on a board exam, which direction does the lens deviate? If that's a question on a board exam, please send me an email so I can complain to the American Board of Medical Genetics. We have a lot more important things to remember than that. And if that's the only thing you're remembering, you're missing the boat. But it is a common finding and causes pretty significant vision disturbance in people that have it. Also, just to point out, this photograph I put in here is actually flipped upside down so that the dislocation would be in the right direction. I think this patient actually has Marfan syndrome. Anyways, that's what it looks like. Let me go back to that for a minute too. The other thing is you can see here these little spots on the iris. If this were a video, what you might see with a dislocated lens is that that iris kind of, it wiggles. It's like a can of worms. It's just wiggly, and that finding is called iridodenesis. And so even if you can't see the lens dislocation, that iridodenesis or sort of wiggly iris can be a marker that there's been a dislocation. The scary thing about homocystinuria, though, of any form, is that they can develop thromboembolism, and it may be the presenting sign in kids with or people with late onset B6 responsive forms. And they can present with DVTs, they can present with arterial clots, they can have strokes, and like every other increased risk factor for clotting problems, environmental triggers contribute and exacerbate the risk. So thromboembolism is a big concern. That can be atherosclerotic disease. It can be venous thromboses and in both of those images, you can see there's lots of collateral circulation. You can have strokes. This was a stroke that was the presenting finding in a person with a pyridoxine sensitive form. So homocystinuria, classical homocystinuria is this transsulfuration pathway. The remethylation pathway also leads to hyperhomocystinemia. And I'm not going to go, we're running out of time, and I'm not going to go too deeply into it, except that the methionine is often not elevated in those cases and can in fact be low. And so in some of those cases, you actually can have problems related to low methionine. So you really have to be careful to monitor methionine. It's really important when you see, because B12 metabolism has such a large role in this remethylation pathway, when you have a suggestion of a defect in propionic acid or methylmalonic acid metabolism, you need to check homocysteine and make sure that you're not missing a more complicated B12 deficiency. And like everything else, you shouldn't treat people, you should always do as much as you can to get a definitive and conclusive diagnosis, and that usually includes DNA testing. So switching back to classical homocystinuria, pyridoxine responsiveness is usually tested by giving 10 milligrams per kilo per day with a maximum dose of 500 milligrams, because high dose pyridoxine can cause peripheral neuropathy. So in children, we usually max out at 5, even in adults max out at 500. And you give it for 4 to 6 weeks and measure homocysteine a few times before starting and a few times after, and see if there's a greater than 20% response is considered responsive. We usually treat all patients with homocystinuria with folic acid, because folate is intimately involved in remethylation, and it doesn't fix the problem, but it's probably helpful. And if B12 is in any way deficient, it's valuable to give supplemental B12 as well. A low protein diet with low methionine formula can be helpful. And then this scavenger drug betaine that uses a different pathway to remethylate homocysteine to form methionine that works. It's interesting, but the enzyme that makes that drug work is called betaine homocysteine methyltransferase. There's humans have 2 forms of that. It's not entirely clear what either one of them is evolved to do. But most people can tolerate up to 200 milligrams per kilo per day. Once you saturate the BHMT enzyme pathway, you don't get any additional benefit from by giving more betaine. So it's because it's an enzyme-driven response, it is a saturable process, like many metabolic processes. Lots of novel therapies in the pipeline for classical homocystinuria, including clinical trial ongoing right now for enzyme replacement therapy. this is one of those drugs for which there's an engineered probiotic that's meant to reduce intestinal absorption of methionine. So that's in clinical trial. Gene replacement or correction therapies are in development. I don't think any of those have reached clinical trial yet. And then, interestingly, inhibitors of the proteasome have been suggested, and I'm not entirely clear on what the mechanism is there. I did want to just briefly mention methionine adenylyl transferase 1 and 3 deficiency. It's a rare defect in the conversion of methionine to S-adenylyl methionine, and that's a bad thing to have because S-adenylyl methionine is a very important methyl donor to a variety of pathways. That said, not at all clear if there are clinical implications of this or not, other than having high methionine. And if there are clinical manifestations, it's not really known if that's due to S-adenylyl methionine deficiency or excess methionine. We do know that high concentrations of plasma methionine can lead to increased intracranial pressure and cause symptoms and death as a result of that. It's really not clear how to treat those patients. If you limit methionine too much, you may make inadequacy of S-adenylyl methionine worse. So the question is whether you need to consider both ways of treating. The good news is it's rare and probably won't have to treat it. Most of us will never be in that situation. So that's, I know I went a little bit long. I apologize for that. That's the end of the slides, a few acknowledgements that you can read there, and I'm happy to answer any questions. Looks like there's a few.
Thanks, Sean. A lot of that is back and forth about peg valuase dosing and going up above 40 to 60 and 80. I don't think we have done that here. I haven't seen any patients on the higher doses. I don't know if your experience is different from Cleveland or if you've seen it here.
No, the reality, I hadn't done that in Cleveland. In fact, that when I left Cleveland, we were kind of just getting started with our program there. I don't know if anyone's on from there, but and then, but some of you may not realize this, but in Colorado, we have a wealth of metabolic geneticists, and so there's so many of us that people kind of we have experts in different areas, and so Jan Thomas, my colleague, Jan Thomas and Ina Kochar primarily manage the PKU patients here so I don't have a lot of recent experience with peg valuase. I also want to give Janet Thomas a shout out because she's the one who pointed out this malleolyl hydratase insufficiency as a cause of false positives for succinylacetone on newborn screening. I was not aware of that till Janet pointed it out to me. So. Any other questions?
Rodrigo said we have one patient who just got bumped up, so it's good to know. Any other questions for Dr. McCandless?
Looking back, Lorenzo, you have a question about the math on one of the slides. Which slide was that? Because there are a couple of slides that I took from NAMA where I thought I'd fixed all those problems, but there were a couple of slides where I took them from other people and I haven't fixed all the errors. It's also entirely possible that I've introduced an error on my own. I am very good at doing that too, so don't need any help usually to introduce new errors. But if you can zip me an email if you want to, and I'll try to fix it. Or you can make the point now so nobody goes away with the wrong idea.
Oh no, I mean it's just a small thing. It was going through the math in my head, but if I see the slide again, and if I think there's still some tweaks, I will send you an email.
Okay, I think there was one thing as I was reading it, I was wondering about, and it had to do with the nitrogen content in the muscle.
Yeah, that was
protein. Yeah. I'll double check that, and if I get it, if I figure out what the problem is, I'll correct it. Thanks for pointing that out. Any other questions? Everybody's so soundly asleep.
It was very interesting, thank you, and quite a tour de force with all of that important stuff. crammed in an hour and 28 minutes. So thank you.
Well, thank you all for your attention. It's a lot of fun, and I'll look forward to my next opportunity to chat with you.
Thank you very much, Sean. Everybody tune in next week with Dr. El Garbawi and carbohydrate metabolism, and have a safe, fun, good weekend. See you next week. Thank you. Bye. Thanks, Sean.
Thanks, everybody. You're welcome. Thank you all for your attention.